just going to give everyone a few minutes to gather, and then we're going to jump right into this afternoon's conversation. I think everyone is still gathering, so thanks for your patience. Hope everybody's having an okay day. Okay, I think we've got some gathered, so why don't we begin? Welcome everyone to the fourth and final webinar in our Strategic Thinking series, co-sponsored by the Transforming Chaplaincy Project and the ACPE. We are very happy today to welcome Linda Wilkerson, who is the Director of Pastoral Care at the Parkland Health and Hospital System in Dallas, Texas. And she's going to talk with us about how strategic thinking helped to create the Metro Dallas Faith and Health Initiative. Before Linda begins, let me just remind you that this webinar is being recorded and within a few days will be available on the webpage of the Transforming Chaplaincy Project, and I believe also through the ACPE. We will follow up after this by sending the link and any handouts, the PowerPoint slides as well, to all of you, and they will be available on the website, so share them widely. Linda, thanks so much for being with us. Linda's going to talk with us for about half an hour, and then we're going to take some Q&A. Anybody who wants to open the chat box at the bottom of the screen, you're welcome to do that and chat while Linda talks. But just to make things easier, we're going to take all the questions out of the Q&A box. So if you have questions as Linda's going along, please feel free to type them into the Q&A box, and then I'll do the best I can to get as many of those questions as I can to Linda once the Q&A starts. So Linda, thank you, and the floor is yours.
All right. Well, thanks. I really appreciate being asked to do this. It's a little bit daunting to talk about this project and how we managed to get from zero to where we are now, but I am looking forward to talking with everybody about that. And one of the things that's happened as I've been preparing for this is realizing that, you know, when you're looking backwards, you realize that there were some places where you had a clear strategy, and some places where you realize that what you were doing was strategic, but you weren't really thinking about it. And so it'll be interesting for me to try to talk to you about that process. And so I'm going to share my screen with you because I have a PowerPoint, and let me see if I can get this piece to you. So give me just a minute. And with the first, obviously, we're going to talk about the DFW FaithHealth Collaborative. And I think this is probably important to begin by just saying a little bit about what this DFW FaithHealth Collaborative is. It's essentially an informal, though it has some elements that are pretty formal, partnership between, right now, 4 DFW health systems. That's Baylor Scott and White, Children's Health System, Methodist Health System, and Parkland Health System. And then many, many area faith communities of all sorts and types. And our goal is to leverage the resources of both faith communities and the health systems to improve the health of the community. So I want to say, I'm going to just tell you a little bit about kind of the way I think about it, sort of the story in a nutshell, and then I want to go back and talk about how some of the pieces that got us to where we are, because I think that a little bit of backstory would be helpful to you. So in 2013, I attended a faith health conference at Wake Forest University Health System, along with Mark Grace. He's actually both my husband, but he's also the Chief Mission and Ministry Officer for Baylor Scott and White. And we had heard about the Faith Health Initiative that was going on at Wake Forest. They held a one-day conference, and we went to just explore that. And part of, for me, my thinking at Parkland was just kind of looking out into the future and thinking about where pastoral care was going, where we needed to, how we needed to be positioning ourselves to continue to be relevant to our health system. And it's particularly, I mean, I guess it's important for every health system. It's really important at Parkland. We're a public healthcare system. And so the money is always tight. Making sure that the institution understands what pastoral care is doing and what we're about is really critical. And thinking along with the institution about where we're headed was really important. So I went to this conference and came back really excited about it. 2014 was kind of I would call this a year of percolation and planning. We didn't have any money to really do this, and our health system is always really stretched financially. We don't have a lot of free cash floating around, and so I had an idea about what it would be like for Parkland to build partnerships with faith communities, but and I began to sort of have a model for what that would look like, but I didn't really have the resources yet. I also didn't have the support in the institution. Luckily for me, towards the end of 2013, beginning of 2014, I've been moved around this system and reported everywhere from the CEO to VPs of this, that, and the other. We made a change at Parkland in our organizational structure, and I began reporting to a new vice president of inclusion and diversity. And honestly, I'll tell you, I wasn't thrilled about that when it first happened, but it's turned out to be a really wonderful thing because of the person that's in that role, Ildemaro Gonzalez. He is very much a forward kind of strategic thinking guy. And when I told him about this conference that I had gone to, he immediately saw the potential in that as well as I did. But we were, still, not having a lot of resources and just beginning to think about it. I think it was in 2015 that as I was thinking about it and just doing some initial sort of laying the groundwork, I realized that one of the big differences between Parkland and the two other places in the country that I knew about that were really doing this, one, of course, being Wake Forest and the other being Memphis, and I'll say a little more about Memphis in a little bit. Those two places, the territory that they covered was very different. And Memphis, they have a great program going. It's been going for 10 years. They have 600 congregations involved with Methodist Le Bonheur. So let me give a plug to them because it's an amazing program. And one of the persons who helped establish that program, Gary Gunderson, was recruited over to Wake Forest in North Carolina to do something similar there. Wake Forest is a very kind of large rural area. Memphis is a very, certainly an urban area, but pretty consolidated. And they had a healthcare system that had 70% of the market share. So when I started thinking about how we might do this, I realized pretty quickly there was absolutely no way for Parkland to do this by itself, that the community was just too large. We didn't, we had a lot of different health systems that were doing different things with the faith community. We had never, at least to my mind, had a real conversation about what everybody was doing. And so in 2015, I really started inviting folks to the table around the health systems. And really my initial conversation with them was just, do you want to come have lunch and let's talk about the possibility of our partnering together around our relationships with the faith community. And the way I talked about it at that point was simply that we didn't want to be, I don't think any of us wanted to find ourselves in the position of competing for the faith community. And I've had enough, conversations with faith leaders in Dallas to realize that they felt as stretched as we felt. And so I also was trying to avoid each of us having, trying to pull on the same people out in the faith community to assist us. So we began meeting and having conversations, and really very informal at first, talking about what we were each doing, sharing that with each other, and then beginning to think about what it might look like if we worked together. And out of that grew a time when we met together and we talked about a possible mission and vision. And so we began to sort of put some pieces like that together. In 2016, Parkland launched its 2020 strategic plan. And I'm at an institution that has flown by the seat of its pants a lot of the time that I've been here. I've been at Parkland for 17 years. We have not always had a clearly articulated strategic plan, but we had a lot of new leadership. We had a CEO that had been here, I think, in 2016, a couple of years. And so things began to really percolate, get going, and they developed the 2020 strategic plan. And one piece of that strategic plan, there are 5 key components to it, but one piece of it was community partnerships. And so that piqued my interest right there. I thought, wow, I've got a project that I think might fit into that. And then, amazingly enough, because I didn't have the resources, I knew I was going to have to build a pretty remarkable case in order to get resources. We had a physician who had been on our PAG and has been a physician at Parkland for many, many years, who passed away. And she left her estate to Parkland. When she did that, she left her estate to Parkland, which was a significant amount of money, about $3.5 million. And she clearly noted in there that she wanted this money to go primarily to pastoral care. She had some relatives who appeared and who contested the will. And honestly, when the contesting of the will took place and I did depositions, I kind of put it out of my mind. I really did not think that Parkland was going to get this money. They hired a pretty high-powered law firm. And so I kind of put it to the back of my mind. And then one day, out of the blue, I get a call from our foundation saying that this suit had been settled. They had gone before the judge, and indeed the money was coming to Parkland, almost all of it. And at that point, I realized that, wow, this was going to be very interesting because the money was left to Parkland, but clearly in the will she talked about wanting it to go towards pastoral care. But we were also at that point in a really, our financial position had gotten even more serious, and it was very difficult. And so I just honestly didn't know whether the institution was going to feel like they had the leeway to really give the money to pastoral care. So I started thinking about that, planning. I'm going to say a lot more about that in a moment. And it turned out that money did eventually come our way, and I'm going to talk about how that happened. And then that led to us in 2017. This year, we've been doing just an incredible amount of program building and launching. There's a lot of pieces to get in place, everything from publicity to websites to training to recruiting congregations, all of that. And hopefully by the end of 2017, or at least by the end of our fiscal year, I hope to have 45 congregations that are working with us. So let me say a little bit more now about kind of looking back on developing a strategy for this kind of initiative, or any kind that you might have. I think one of the first things that everybody needs to do, no matter what you're doing, even if you don't have a set plan, is to find and cultivate the supporters in your institution. That's, when I came to Parkland, I met Dr. Alice Smith. She had been giving a luncheon for our pastoral care department every single year for probably 20 years. And I was here, and she continued to give that luncheon every single year to recognize pastoral care. She was a Baptist laywoman. She was very instrumental in helping Parkland get pastoral care way back in the day. That actually, when President Kennedy was shot and came to Parkland, we didn't have any pastoral care, and they kind of literally, she was there. They had to run around and find a priest, and so that sort of galvanized her interest. So when I came as the director and began to get to know her, one of the first things I did was invite her to be a part of our pastoral care advisory group, because clearly she was interested. And I want to stop for a moment and say, it sounds like I've done everything by myself. That's certainly not the case. I had a wonderful colleague, Leo Blanchard. He was a CPE supervisor here with me for many years. He developed a relationship with Alice. In fact, he may even have been the one who made the invitation to her to be a part. But one of the things that I've realized looking back on that is that finding and cultivating supporters throughout your institution is critical. And you want to look for people who, number one, have an interest in what you do, but you also want to look for people who are interested in what you do and have some influence in the institution. The second thing I think is really critical when you're developing a strategy is to know what your institution's strategic plan or direction is, and to really understand it and go talk to people about it and make it your business to be interested in that. I think that there's nothing that speaks more powerfully to an institution, especially from pastoral care, is having the leadership of pastoral care really understanding where the institution's going, being interested in that, finding out about it. And, that's the way that you begin, number one, to let people know that, yeah, you are interested in strategic, work as well as they are. And sometimes I don't think pastoral care is all that interested in that. The next thing, obviously, once you've just determined what the institution's strategic plan is to think about your role in that strategic plan. What is it that you want to do? So I've already talked about talking to the leaders about the plan, but thinking about what's the strategic plan for your department. And I know in another of these webinars, we had a really great example of folks doing that and planning out and thinking, well, what does the future look like for us? I really do believe that none of us in pastoral care can sit back and think that we can keep doing what we've always done. Every healthcare is moving, 90 miles an hour. There are always lots of new directions and new opportunities. And so I think it's really critical to start really thinking seriously about, well, what's the plan for my department? And how does what I'm doing connect with what want to do connect with what the institution's plan is? And, having conversations with the folks that the department reports to about that. And if I've actually reported to people who I would say probably weren't too interested in having that conversation with me. That's not the case right now with Ildemaro. But when I think if I were in that situation, I would just start talking to other leaders. Somebody in your institution is leading the strategic plan, or has some idea of where your institution is going. And so talking to those people about what they're doing, demonstrating interest, and talking with them about what you're doing and how you see what you're doing connected with that plan is really important. Then when it comes to your own strategy, is to make a plan and have clear talking points. And so one of the things that happened with me in ours was that as I began to get a more clear sense of what a faith health initiative would look like, I really did start developing sort of key talking points about that faith health initiative, what I envisioned that to be, how I thought it was going to be helpful to Parkland, how I thought it was connected to our strategic plan. And I just started literally going around the institution and sharing that with anybody who would listen. Now, I wasn't, I did have some strategy to that, because clearly there were people in my institution that were very interested in what was going to happen with community partnerships. And so I identified those people. Our VP for population health, we actually have several of those. We had somebody who was leading the strategic plan. I went and made 30-minute appointments with all of those people and talked with them about my understanding of where the institution was going, and where I understood that the Faith Health Initiative could take Parkland. And I don't think I can emphasize enough the fact that having a lot of people to understand what you would like to do and begin to get their buy-in is critical to ultimately getting your institution on board with something you want to do, because you're going to need supporters and you're going to need people, or at least I'll say I did. I needed supporters and I needed people to say, oh yes, that $3.5 million that we could definitely use in the general budget, it really ought to go to pastoral care because they've got a fabulous idea about how to spend that money, and it's going to make a difference for our patients at Parkland, and it's going to move us down the line. I think I've said a little bit about this, but sort of be ready to strike when the iron is hot. For me, that just means, you make a plan and you never know when or how you're going to have the opportunity to speak to the right person about that plan and really tell them what you're doing. So, having your talking points, having your elevator speech, that little, 2-minute blurb about the project that you'd like to see your institution support. Obviously gathering support from those with influence. So this was really important to me because there came a point at which I got a call from the foundation and the money was in hand at Parkland, but there was going to be a very key conversation about where that money was actually going to go. And I actually was feeling not so confident that that money was actually going to come to us. Because we were in a difficult financial situation. We had just gone through, budget cutting for everyone, and I knew how tight things were. But I also really believed in this project, and I knew that what we were about to do was going to pay off in benefits to Parkland. And so before that meeting, and I actually found out that our CFO was going to be there. And when I found out our CFO was going to be in the meeting, I was like, oh no, this isn't going to work. But I pressed on, and I found out who all was going to be at that meeting. And I went and talked to them, most of them, about the project and what we were planning, what I thought that money would be used for, and how we could benefit Parkland and how it would connect to the strategic plan. And I also think that it's really critical to plan for how to respond to objections. So to think about, from other people's perspective, what are the things that they're going to raise in terms of, reasons why the institution shouldn't do this or can't do it, or problems that might develop as a result of it. And so I did that work as well, and, kind of had that, those talking points available. And then the last thing I'd say is to develop a really convincing presentation that speaks the language of the institution. And I don't know about you, but here at Parkland, facts, figures, those are the things that really speak. The language of the institution here is, tell me in dollars and cents or in patient satisfaction figures, or, give me some things I can hang my hat on. I don't think that means that you can't use anecdotal information or stories, because I think that really fleshes out the whole presentation that you make. But from my own standpoint, I think pastoral care leaders tend to lean on those stories and don't have as many facts and figures. Luckily for us, we had a tremendous amount of data and research that came out of Memphis. And so we knew what their program had done. We knew what their how much money they had saved the institution. What we intend for with our partnerships with our congregations is, to provide them with a lot of resources, a lot of training, a lot of assistance, so that they can help us support discharged patients. Because we know that discharged patients often return to the hospital simply because they don't have enough emotional, social, and spiritual support in the community. And so we want congregations to build health ministries inside of their congregations so that they can care for their members that have been discharged from the hospital, but also so that they can reach out into the community and care for folks who may not be a part of their particular congregation, but who live near them and who need key support. There's a lot of research that basically says, folks who don't have the kind of support that congregations are really good at providing often get readmitted to the hospital earlier and more often than folks who do have that support. And of course, all of our hospitals now are paying a lot of attention to readmission rates. And so, we kind of had our facts and figures together. And at our meeting, when we, made the presentation, used the facts and figures, we certainly did talk about key anecdotes. One of those was talking about Dr. Smith and her long relationship with our department. And at the end of that meeting, amazingly enough, our CEO basically looked around the table and said, well, as far as he was concerned, it was very clear that this money clearly needed to go to pastoral care, that we had a great program, then basically said this is exactly the kind of thing we want to fund, and we're going to have to find funds outside of our operating budget because we just don't have it. So, in some ways, everything kind of came together in perfect timing. But I also believe very strongly that it was some strategic preparation that we had done that got us to that point. And then the last thing I would say is once you have, gotten your project approved and you're beginning to be able to kind of get that off the ground, that it's really important to stay in touch with the people who supported you and give them regular updates on what's happening, how things are going, the direction that you see things are happening. For us, one of the things that happened that has been both a wonderful thing and a little bit frightening is that our project actually was chosen. Each one of our 5 strategic initiative objectives, our senior leadership determined that there were not going to be any more than 3 projects for each one of those 5. And our Faith Health Initiative was one of the projects that was chosen for the strategic plan under community partnerships. And that has given us tremendous visibility. One of the things that came with that was a project manager to work with us all year long to help us stay on track and stay focused. And, again, what I would say is it's a blessing and a curse. It's a wonderful thing because we need that sort of support and help. But it's also, it's the first time in my career that I've done a project that had such high visibility in the institution. But, even with that, it's a wonderful thing. And I'm really delighted that we've had this opportunity. And me and the other folks working with me, we've learned so much. So I think at that, the one other slide that I have here is because I thought some of you might be interested in knowing more about Faith Health. So you can see the Faith Health NC website and also the Methodist Health website. Both of them have just terrific information about their programs. And I invite you to take a look at those if you're interested. And I think with that, I'm ready, Wendy, for any questions or.
Super. Thanks, Linda. That was really helpful. So we've got 2 questions in the queue. We'll start with those. And others of you who have thoughts and questions, please add them to the Q&A box and I'll do the best I can. So the first question is, could you give us any more specifics of what you actually did in your, I assume, strategizing and planning?
So, some of the specifics I sort of talked about after I talked about the whole story, but, I specifically did, I made a written plan. I made key talking points. I gathered facts and figures that I thought were going to really speak to my institution. And, again, as I said, I was fortunate that I had a lot of good research. That's one thing I would say is that in our institutions today, research really speaks. And so, I would say, anything really that you want to do. For example, I kind of have out in my mind after I kind of get the Faith Health thing bedded down, one of the things that Parkland doesn't have is any kind of medicine and the arts program. Well, I know that if I'm going to develop a medicine and the arts program, I'm going to have to do some research, and I'm going to have the research, data at my fingertips in order to talk to people about why this would be important and how it would be impactful. It's one thing to say, oh, isn't music and dance and art wonderful? And we all know how good that makes us feel. But when you're competing with, the ICU for dollars, you have to be able to say, this is how it's going to help our patients. And, here's some facts and figures, because the stories just don't generate enough resource for you. Mm-hmm. So, as I said, finding out who in the institution that I felt honestly was going to have an influence on the decision making was one of the things that I did. And, figuring out who those people were and going to talk with them and getting them on board. Because when we were in the meeting, I think of it as the pinnacle meeting where we were going to decide whether or not we were going to get this money, and that was going to have everything to do with whether we could do this program. Although I gave the presentation about the project, and I talked about the relationship of Dr. Smith to our department. It was my other people around the table, and really mostly vice presidents, who chimed in and said, we think this is a fantastic project. I can see how this is going to work in population health. I've already been thinking about how this is going to work, in our clinics, mm-hmm. and how we can put these things together. So I wasn't the one doing the selling. It was really the other people around the table who I had already convinced and sold on this, who basically came ready to say, no, this money should go to this project.
Mm-hmm. Thanks, that's helpful. Another question, could you tell us how you trained the faith community leaders so they would be supportive of the project and the goal?
Well, so it was actually, that was really interesting. I left this part out. So one of the things that we learned, after we went to Wake Forest, I realized that Memphis Methodist Le Bonheur in Memphis was also having workshops about their program. And so we went there. That was incredibly helpful to us. And one of the things that they talked about when they started their effort, which was now 12 years ago, they gathered a group of key faith leaders from the community and did this sort of brainstorming together, because they were starting from scratch. They didn't really know what they wanted to do. They just knew that they had a problem at Methodist Le Bonheur. In their situation, they had the other hospitals had moved out of the inner city. Methodist Le Bonheur, which was not which was not a safety net hospital, was spending a lot of money on folks that didn't have insurance. And so they really needed to do something and figure out how they could get the community healthier. They realized their untapped resource was their faith community. And so they got a group of folks together. Well, we weren't starting quite from as scratch as they were, because we had their model, but we did realize that we needed to get faith leaders on board pretty quickly. So we started really kind of at the same time that I was talking to other health systems, I started having faith community leader meetings and invited a huge group of faith community leaders to come to Parkland. Then we went out into the community. We had one of those meetings at a Baylor Scott and White site. We had one of those meetings at a Methodist site, Methodist Health System site. And all of that was to explain what we thought a faith health partnership could look like between the health systems and the faith community. And eventually we managed to get what I would think of as a core group of faith community leaders who are also in support of this project, and they meet monthly. Mm-hmm. And so once we got those folks on board, in a sense, we were all learning together. We were sharing information with them about what we'd found out at Wake Forest and about what we'd heard at Memphis. We were having lots of sessions with them where they gave us ideas for what they wanted to see, because we really want it to be a real partnership. We don't want it to be the health systems telling the faith community what to do. I think that would be the death knell. We really have to hear from the faith community about what is it that they need and want. One of the first things they told us was they wanted a robust resource hub. And, what they realized was that, they would had little resource lists. They'd send a parishioner out to, some place to get food or clothes or whatever, only to find out that it was closed. It wasn't open anymore. It didn't serve the people in that zip code. And so we took that seriously, and we have been heavily involved this year in building an online resource hub that gets as much resource information as we possibly can. Mm-hmm. And one of the ways that we've done that is to get some Master of Public Health interns to work with us. They have to have a project, and we've got a project for them to do. So it's sort of free help and helped them win-win. Mm-hmm. But then we started, in that sense, we were learning together. Now we have training modules that we take out to the congregation. Whenever a congregation signs up with us, and we have a covenant that they sign, when they sign up with us, then they identify who their health ministry volunteers are going to be. We have a set of training materials that we use to offer initial training to them. And then our goal is to do what Memphis has done. Memphis has this wonderful, they call it their church, I think they call it the Church Health Network Academy. We're thinking about having something like the DFW FaithHealth University. We really we're in the process of talking to some area colleges and universities about how we might offer some credit for some of the classes that we offer through that university. And we want those classes to be things that the health systems that the congregations tell us they want to know about. And then we're going to find the subject matter experts to speak to those. So an example is diabetes education. Probably most hospitals right now have some good diabetes educators. And that's information that healthcare systems are really that congregations are really interested in. Another one of those is mental health. What do we do with people who come to our congregations who clearly have mental health issues? Mm-hmm. So we've got the subject matter experts. We can begin to build some curriculum and help for congregations. Mm-hmm.
So there's a related question here about how you got buy-in from local congregations. And what I hear you saying is you heard them very clearly about what they needed, and you started to try to provide that relatively quickly in the hub of resources, in what you described now, trying to have sort of courses on topics that they need. Right. Are there other ways that you tried to get buy-in from local congregations? And did you work at all with faith community nurses in that process?
Well, actually, yes. So a couple of things. So Parkland doesn't have a faith community nurse program, but Methodist does. And that's one of the wonderful things about our collaborating together is that, we don't have to reinvent the wheel. So now when we come across a nurse, let's say at Parkland, who is interested in being a faith community nurse, we're not going to offer that training at Parkland because Methodist already offers it. But we will help that person get connected, and we've actually also taken some of our money and decided that we would offer some scholarships. We particularly will offer a scholarship to someone who wants to become a faith community nurse, who is then going to start a health ministry in their congregation and sign a covenant agreement with us. So that's one way that you get buy-in, is by supporting the needs and the folks out there in the community who want to be a part of in some way faith community health or faith community nursing. Mm-hmm. But other things that we did to get buy-in from congregations, I think probably the biggest thing we've done is to have a lot of education/listening sessions. So pretty much everything that we find out about any faith health program anywhere in the country, we bring it right back to that faith leaders group. And they were heavily involved with us in creating the covenant. We didn't do that by ourselves. They really are a steering committee. We depend on them for guidance. And there have been several times when we were going to head off in one direction, they were like, oh, no, we don't think that's a good idea. And we listen to them because they're out there. They know what works in the faith community and what doesn't. Mm-hmm. Is everybody on board? No. Have we had congregations that said, no, I'm not interested? Yes, we have. Sometimes that's because they just have other irons in the fire and there's only so much bandwidth. Sometimes it's because they've seen health systems come out into those communities and try to do work and, essentially didn't follow through on their commitments. And so the lack of trust is one of the things that we have to deal with. And I think, the most important thing we can do is be faithful to what we say we're going to do, to hang in there with it for the long haul, and to demonstrate that we mean what we say we mean. So I don't know if that's
there is one question about the flip of this, which is about, have you done things to facilitate medical or healthcare training in the area of faith community? So someone wrote, we have done much of the planning you were talking about, and we have a manager of congregational health. What have you done to facilitate the medical/healthcare training in the areas of faith communities?
I don't think I quite understand.
I think the question is, have you done things beyond what you've talked about to help people in the medical setting get on board with what's going on in faith community? So you've been talking about how you got the faith communities on board. You talked already about how you got your medical colleagues, but is there any more to add to that?
Well, so, some of the supporters of our project to begin with were physicians. But they were physician leaders in our institution. So we got them on board. Probably the next thing that's happened where we've really worked at this is we've just developed a new part of EPIC, which is our EMR and electronic medical record, where we are going to be, our patient registration folks all throughout our system, inpatient and outpatient, are going to be capturing now not only the faith background of our patients, but whether they're connected with a specific faith community. And so in doing that, that has brought me into contact with a lot of physicians and other providers, nurses, and everybody, explaining to them what we're doing, why we're doing, because every time you make a change to EPIC, that's a pretty big deal. And so that was a great opportunity. Actually, it went before what we call our end user group, which is a group of physicians primarily who are looking at everything that's in EPIC and making decisions about what can stay, what can go. And so we had an opportunity there to talk to that group about what we were doing and why, and to get some buy-in from them. Mm-hmm. That's one thing. Mm-hmm. I think we've got work still to do on that.
Mm-hmm. Okay. Two more sort of research-oriented questions. Someone wrote asking about the literature that looks at the impact of congregational support on reducing readmissions, and said that they haven't found much in the literature to support that. So they're wondering if there are specific articles that you had looked at that found a relationship there that you could share?
So that material, most of the material that we got came from Memphis. And so I would really, highly recommend that folks give Methodist Le Bonheur a call. Bobby Baker is the director of the Faith Health initiative there. And they've had, I think in their 12 years, they've had 2 pretty significant studies done. And they were basically outside folks who came in and looked at their program and studied it, and did come up with a definite relationship between basically some data about the impact of their faith health program, both on patient readmissions, on the total cost of patient stay, and one other thing that it's escaping me right now. So that's I don't know if those studies have been published anywhere. That's a really good question. I think they have, actually, but I got them through Methodist Le Bonheur.
So do you have them that you could share with us, or shall we try to get them and send them to the group?
Let's see if we can, I'll see about talking to Methodist about that, and we'll see if we can't put something up on the website. I think we kind of have to talk to them first.
Yeah, awesome. Okay, so we'll work on that. Another related question is about what your evaluation strategy is. Specifically, what metrics are you using to determine success or effectiveness, and how do these metrics ladder up to your system goals?
So we're working on those right now. That's actually, we don't have them fully in place. That's part of our plan for this year, is to determine what our metrics are going to be. And I do think that this will probably be a metric that we're going to measure 2 or 3 years from now. But we will be looking at readmission rates, which clearly ladders up to some of our strategic goals. And I'm not sure what else, but I know that's one of the things we're going to be looking at. But that we actually have just been having those with our project manager, those evaluation metric conversations.
Mm-hmm. Super. Does anyone else out there have questions? I think I've worked through everything in the Q&A box, and we've got a few minutes for 1 or 2 more if anybody has something they'd like to raise that we haven't talked about. I'm giving people time to type, so type away if you're typing.
Yeah.
So I can see the question pop up here. Someone asked, how does it actually work? Do you contact faith communities about people being discharged?
So the way it's working here is that, so we have our patients identified as they come in. We know which congregations are partnered with us. And so we have a list that comes out every morning. So we know who's in the hospital, who is a part of a partnered congregation. So we go to visit that patient, and actually the chaplain who's serving that unit visits that patient as a part of their regular work, and introduces to them the fact that the congregation that they listed as being the one that they attend is a part of our faith community health program, because not every congregant knows about that. Explains a little bit about the program and asks them if they are interested in having support from their congregation when they get discharged. If they say yes, then we have them sign a consent form, and then that consent form stays with their chart. From that point, once they've signed that consent, our faith community chaplain, we have hired, we have 1.5 right now FTEs that are faith community chaplains, would get notified that this is a patient who wants to be a part of the program. We'd have a conversation with the patient about the kinds of things that they think they might be in need of. We'll share with them, what the congregation might be able to provide. And then we would make a contact with the health ministry team leader. We call them faith health liaisons in the congregation, to say, hey, we've got Mr. Smith who's in the hospital. He's due to be discharged in a few days. He would like support from your congregation, and we've told him that you will be giving him a call when he's discharged. And so that's how that works. And then the congregation takes it from there. But the faith community chaplain is in contact with that health ministry leader to make sure that everything's going okay, to see if that patient has requested resources that they don't know anything about. How can we help them, really with pretty much anything that they might need.
And when you have patients who are not a part of partner congregations, maybe they belong to other congregations, maybe they don't belong to any congregation, right. Do you do anything with them, or do you just let them be?
So we're kind of working that out right now. That's really a key piece of what we want to do, and that's part of what we're still building. But what we've done thus far is Parkland has, we have what's called it's a virtual unit, a transitional care unit. And we have some software that Parkland developed. It's really getting popular. It's called Pieces, and it determines, it looks at patients not just in terms of their medical history, but a lot of socioeconomic factors, and determines who might be at risk for being readmitted. And then that software gets we have a group of case managers and social workers who do nothing but sort of look at that software, identify these patients, and so we have an idea of who our high-risk patients are. And so our plan is in fact, we're working on it right now. We're going to pilot 20 of those patients. We think we're going to pilot them from a diagnosis group. So we're probably looking at finding 20 high-risk diabetes patients. and these are at high risk for being readmitted. And so then we will contact, they have to be in or near, we identified 3 zip codes that we're really working heavily with. It's not that we don't have congregations in some others, but we have 3 where that we selected because Parkland has a high volume of uncompensated care there. So we know that there's a lot of need. And then we're using those, we're trying to recruit congregations in those zip codes. So as we have one of these high-risk patients that lives near one of our congregations, then we will go to that congregation and say, hey, we've got a patient who's being discharged, doesn't belong to your congregation, but lives, within 5 miles of your congregation. Would you be willing to support this person? And so that's really kind of how we're planning that. Then we would do the same thing with that person. We would have them sign the consent. We'd talk about their needs. So we'd be in contact with that congregation's faith health liaison, and they would contact the patient upon discharge.
Mm-hmm. Got it. Thanks. That's really helpful. Maybe as a last question here. Oh, wait, here are more questions coming in. There is a question from someone asking about if you have any knowledge of other funding sources. That's wonderful that a doctor's estate became the beginning of the program.
Yeah.
You have information about funding sources for people who don't have access to such a gift.
I know. That's the perennial question.
The $25,000 question.
It is. So I don't at this point. I would say this. So even with our gift, we realize that it's not going to sustain our program forever, especially as our program grows. And so we are looking into foundations and other resources. We think we've got something of a unique idea in terms of our Faith Health Collaborative with the health systems working together. So we're hoping that that's going to generate some interest on the part of some foundations to fund some of the work that we want to do. All I can say is I don't at my fingertips know, but that's the part of the research that has to be done.
I would just encourage people who haven't already to try to talk with the development offices at their institutions. I mean, having done this at a couple of institutions, sometimes on behalf of chaplaincy organizations, sometimes I think they just don't know what you do. And if there's a way to show not just what you do for the sake of it, but how it's helping the institution, how it's building community relationships, that is a good way to get the ear or the attention of a development officer. And when I look at things like, the Robert Wood Johnson Foundation's new emphasis on the culture of health, I mean, it seems to me like the kind of work and community liaisons that you're building are very much a part of the culture of health. And so I'm not saying that RWJ has money for this, but somebody in the development office should be able to think carefully about that with folks as they look for money. And particularly if you take this program as a model, right? You're not, for places that want to try this, you're not making this up, from the beginning. This has been tested in other places, and how might this work here, et cetera, et cetera.
And I will say this, I think we're pretty committed to the idea that, we're going to do our very best to put this program in place. If we don't see the same results, I mean, eventually, if we get the same results, then I want Parkland to take it over and let it be part of the operating budget. Mm-hmm. But, if we don't see the same results, then, I think we have to be pretty fair-minded about that and say, either we're not doing something correctly and we need to work on it, or this just model isn't going to work here. And we got to stop this and do something else.
Mm-hmm. Mm-hmm. So how about as a last question, can you tell us what lessons you've learned that would have been helpful to know when you started?
Let me think. Well, right off the top of my head, I think the first thing I would say is this has been a much more complex project with many, many different moving parts to it than I think I envisioned at the beginning. And we set some goals for ourselves for this year, that are part of my performance appraisal, that are going to be a part of everybody's performance appraisal that's connected with this, that are pretty healthy. And, I think on one hand, that helps push us along. But on the other hand, I think, if I had thought about how much work was involved, I might have scaled those back a little bit and been more realistic. Mm-hmm. That's one thing. I think that, you can have a great idea. Like it makes all the sense in the world to me for all of these health systems to work together. but that is a big, big project. Helping those health systems, everybody get on board. Basically everybody has to go through their institution's hierarchy to get buy-in, to get resources if they're going to be resources. Every time we do something that's going to have the DFW FaithHealth logo on it, it ends up right now going through 4 different legal departments, at each of our hospitals. And so that's the other thing I would say is I love the idea of the collaboration, but it's kind of a bear to work with. I think it's worth it. I think it's worth the time and effort. I'm not sure that we're going to see the full fruition of that for several years, because it just takes time to build all of that together. So maybe it's just being realistic and thinking about the time that it's going to take, and all the different pieces. I'm kind of a, wow, this is a great idea, let's go for it. And then kind of backing up and thinking, oh, okay, wait, there's this and this and this and this. And so, I've done some learning about that, about that kind of project and about myself.
Linda, this has been wonderful. Thank you so much for your time. And thanks to all of you who were here and asked so many good questions.
Thank you.
I've learned a lot. I didn't know anything about this. So let me say quickly before we wrap up that this is the last of our strategy webinars for the spring. We're thinking this summer about whether there are other topics, whether this is a forum we should continue in the fall. Do you want more strategy webinars? And if so, what kinds of topics do you want to hear about? If you have ideas or responses to that, and you could send them to Kathy Lyons, who is our project manager at the Transforming Chaplaincy Project, that would be wonderful. I've just put her email address in the chat box. If you click that little chat icon at the bottom of the screen, you'll see her email address. So send us your ideas. To the extent that we continue this, we're going to continue it because it's helping you all out, and we need to know what you need. Not promising that we can meet all those needs, but we'll do better if we know what they are than if we don't. A reminder that this was recorded, and in the next few days will be available on the website of the Transforming Chaplaincy Project and the ACPE, as will the slides, and we'll work to get those articles from Memphis and see if we can get them all to you. Thanks again for being here, and have a great afternoon.
Thank you.